Welcome to the first class session of Nursing 908. Hopefully by this point you've watched the video on the syllabus, and we'll get into some specific topical things. Mostly this is kind of a conceptual and background talk, and we'll be getting a lot more factual information in the next talks. So I taught this course many years ago, and at the time it was called Clinical Applications of Human Physiology, and I think that they changed the name predominantly because the national standards say you have to have a course in pathophysiology. The difference is actually not that much, though, because you have to understand the basic normal physiologic processes before you can understand the pathophysiology. We're going to balance the two here. We'll talk a lot about alterations, but as I say, we'll definitely emphasize the normal physiology on a fairly regular basis, too. So I've tried to choose things that have the greatest importance in clinical applications. A lot of things that are important for laboratory assessment, but also as far as treatment decisions. We don't spend a lot of time on amyloidosis because there isn't a great test for it, and there's not a whole lot that we can do for it at this point. There are some things that are kind of on the frontier. I have a couple of patients with amyloidosis, and there are some things that are being worked on, but it's really not the kind of thing that you're going to see in an everyday practice. It's going to be a very specialized thing. And so most of what we're going to try to do here is things that are more common and more generalist. So epistemology, you're in a graduate program, and so I'm going to use some big words. Epistemology is a word that refers to knowledge, to trying to define the limits of knowledge. And so when we look at knowledge, we have to remember the fact that when you're an undergraduate, you're learning facts, and we assume that those facts are correct. When we get to the graduate level, we realize that there's many different kinds of facts, and they're all based on different levels of certainty. And so that's really important to remember. I use Karl Popper as kind of a central factor in how I think about things. Basically, he says we come up with conjectures, we come up with ideas. Then you have to figure out, well, what's the evidence for those things? And so we try to figure out whether we can provide some evidence that will help verify them, or whether we can falsify them. If we can falsify them, we just discard them. If, on the other hand, we find evidence, we have to understand that by nature that evidence is somewhat imperfect. I use the hypothetico-deductive method, as does everyone that is in a clinical environment. So that's basically where you're looking at a clinical situation and you come up with some ideas. Oh, geez, this might be a strep throat. This might be a viral sore throat. This might be mono. And then you have to use a deductive method to then try to figure out which one it is. Hypothetico-deductive is basically mixing inductive and deductive, and that is the way that clinicians think. And we know that you really can't verify any particular statement just because in every individual case it's going to be a little bit different. But we are going to have to come to the point where we realize that if you truly have a contrary case, you may actually have to discard whatever the issue is. We're never completely certain. We're never 100% certain of anything. That's why we use a 95% confidence interval or a 99% confidence interval. We have varying levels of confidence, but unless we have absolutely compelling proof, we're really not very sure of things. And so science is going to progress insofar as when we propose bold conjectures, we come up with these audacious guesses, and then we try to figure out, are these real? Is there evidence for them? Is there evidence to the contrary? And then we move forward in science. So basically this comes down to the concepts, I think the two concepts of falsification, which is we're constantly looking to see if in fact we can find evidence to the contrary and then discard it. I will say that I'm a little bit distressed about certain things such as aspirin for primary prevention. we have 5 or 6 studies that would seem to support it. And then last year or the year before, the Esprit study came out and basically said, no, 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 it's not good. Well, the problem is that all studies have methodology, and you need to be critical of that methodology, and you need to be very careful to discard a whole concept based on one study that seems to quote unquote falsify it, when in fact there may be methodological issues. So we have to be rational, and we have to be very critical, and we have to think about what is the evidence for this, what is the evidence against this, and what do I have as a clinician for skills, and what are the unique cases of the patient. So that triad of evidence-based practice. So I love this quote. Gene Harkless actually gave me this quote probably 20 years ago, and it's basically saying, you know, we're not trying to open a door on infinite wisdom, we're just trying to set a limit on infinite error. So going back historically, my PhD is in sociology, so unfortunately I'm going to bore you with a few social science facts, and that is that since the Enlightenment back in the 1700s, there's been all sorts of figures, Descartes and Rousseau and all sorts of others, that really have been trying to struggle with this sort of scientific approach and the limits of the scientific approach, and then a humanistic approach, and then the limits of the humanistic approaches. So Voltaire, who was another Enlightenment thinker, basically said that there's a great appeal to sort of this great, more scientific approach to things. We think of reason as being autonomous from the church, autonomous from politics, autonomous from anything, and basically it stands on its own. There's an idea that we can move forward, that we can make the information and the knowledge more perfect. We can have a fair ability to discover causality, and basically we can move forward scientifically and really make things more objective. Nationalism, of course, basically pits one country against another, and that is not appealing to most scientists. The problem is that there's limits to this kind of reason, and many people will use supernatural explanations. Well, it's God's will, or there is, a spirit to the body, and that's what defines this. These are very appealing explanations. The problem is that they can't be scientifically verified. The other thing, of course, is that there's many things that we're pretty sure are knowable, but we just don't have the science or the technology to know them at this point. And when you're sitting in a room with a patient and you're trying to make a decision, the fact that it may someday be known is not helpful. You have to make a decision that day and move on. So epistemology, we said, is the study of knowledge. Ontology is a branch of metaphysics which is concerned with the nature and relations of being. So right now, and probably it always will be, knowledge is consensus of the scientists. And of course, as we see from political arguments, there's often scientists on both sides of a particular issue. Sometimes they all come together and agree, other times they don't. And so one of the challenges, of course, of moving to the graduate level is that you can no longer memorize facts. Memorization is not a terribly useful way to learn. In fact, I think that if you learn the patterns and the processes, then the facts will just fall into place and you'll understand them and know them, and that you know them more so than memorize them. So one of my favorite sayings is content follows context. The cognitive psych folks will tell me that there's really not a whole lot of learning that goes on without a scaffold to hang it on. So UNH is an evidence-based practice program. Usually that means that we try to look at the evidence. We try to see what evidence supports things, what evidence disputes it. We understand concepts of sensitivity and specificity. We understand concepts of positive and negative predictive values. And we understand concepts of likelihood ratios. We basically have tried to get into levels of evidence that really do tell us what the science says. The other thing to remember, of course, is that evidence-based practice, as put forward by David Sackett and all of the pioneers, really does not tell you to follow guidelines. It tells you that you need to understand the evidence, and then based on the clinician's expertise and the individual patient, you then make a decision in collaboration with the patient. So again, the research is trying to provide some falsification. If we've tried hard enough, we actually may come to the conclusion that something is true, and therefore it's the usual and accepted practice. We may feel like a certain treatment for cancer, for breast cancer especially, is the best study. They design a study, they use the control groups, they use the study groups, and we assume that there's no difference. So we assume that that's the null hypothesis. If we in fact find a difference, though, we'll reject that null hypothesis, accept the research hypothesis, and move forward with the idea that that this has evidence for it. So in a study for breast cancer, let's say that the people that got drug X died 30% of the time. The women that got drug Y, probably a placebo, died 45% of the time. We then have to look at the size of the sample. We do the statistics and use probability theory to decide whether this happened by chance, whether it's at the 95% confidence interval or the 99% confidence interval, and then we either accept or reject that hypothesis. So we know that the chance of that particular study in a reasonable size sample, which is usually a minimum of 400, much larger than that, sometimes you can get confident results that are really not very big or not very meaningful, but that's a whole nother discussion. We had set our threshold at 99% or 0.01 probability, so we reject it and we say, yep, this drug really works. And the better the study is designed as far as controls and all that stuff, the stronger the evidence. If there's been many studies done, especially if they were randomized controlled trials, then we really do find strong evidence for these things. But the problem is that if you're looking at a study and it says that 30% of the women died with the study and 45% died with the placebo, that really means that only 15% of the women were affected. 85% of the women weren't effective. They either would have lived anyways or they would have died anyways. And so that's the challenge, is we really can't look at a study and say, oh, this drug prolongs life, because in this particular example, in 85% of the patients, it had no impact. And that's the challenge, and that's the ecological fallacy, is taking a study which seems to support a difference and then applying it to a particular individual. We can say that there is a higher probability that this person will live based on this study, but we can't really say with any certainty whether it's going to make a difference. So what makes the evidence strong? Randomized controlled trials are really the gold standard at this point. I'm actually wondering if this may change over the next several years because of the advent of big data. Big data basically is these samples of 100,000 or 200,000 people that the insurance companies have collected. The advantage of big data is that we didn't have to exclude the pregnant women. We didn't have to exclude, people of a certain age or people of a certain issue. And so that's one of the challenges, is that when you have a study and all of those sampling issues, it's really hard to generalize it to the general public. Big data may allow us to do that. We may have to use, triangulation with RCTs, big data, and some other factors. But as of right now, RCTs are the gold standard. But I would just have to say, stay tuned. The design of the study, whether it was the right statistical analysis, there's been a bunch of studies that have come out that have basically said that at least maybe 50% or so of the medical literature has the wrong statistics being done on it or is handled inappropriately statistically. I'm hoping that this gets better over time. I'm not really seeing any evidence that that's true. And the challenge, of course, is that nobody else sees that data usually. You know, sometimes we have these big data sets and you can go back and you can reanalyze it, but if they've collected the data themselves, especially if it was a drug company, they're not necessarily going to share the data so that other people can manipulate it and really look at it. Again, that would be a major advance. The size of the study, and basically that defines the power of the study, and other variables. Some of the evidence is really strong. You know, basically there's a theory that if you split an atom, there'll be a large release of energy. In fact, we've tested that and the bomb did blow up. So I think we're pretty confident that that particular theory is a real thing. But not all theories can be tested to that level. So looking back at the breast cancer, one of the things that's really hard is trying to figure out whether something is statistically significant versus clinically significant. If you've got a sample that the difference is only 5% difference, and the sample size was huge, you know, then you have to figure out, well, you know, 1 out of 20 women might be helped. Is this real? Is there other factors that may be involved here that they didn't control for? And so it's really hard to figure this out. Fortunately, there's more and more sites that critique studies to this degree, Cochrane and some of the others. The problem is that opinion always creeps back in. Up to date is pretty good about reviewing evidence. The problem is that they usually only have 1 or 2 people that are reviewing it, and then they offer their opinion on things. And unfortunately, a lot of people weigh the importance of the actual data with that person's opinion and say, well, up to date says to. So that's a great caution for me. I always look very carefully at up to date, and I always try to look at a couple of other elements too. I like eMedicine. Dynamed is a great resource that a lot of the residency programs are using because it basically just reviews all the studies. It doesn't have an opinion. So you have an individual clinician making an individual choice based on the knowledge of the evidence, and this avoids the tyranny of evidence. There is a great interest in creating guidelines and best practices. The problem with that is that that may not be applicable to your individual patient. So you really have to think about all the different levels of evidence. So physiology. So if we really do understand the basic sciences, it's going to help us critically think through these issues. The problem is that things that seem to fit conceptually don't always work in the real world. There are many people that will provide lots of opinions about science. There's a great number of people out there right now that are very big on the MTHFR gene. And the MTHFR gene is important for methylation. There are people that really test that and then feel like that person has an immune issue. There's not a whole lot of science that really does support that, but that's an example of somebody taking a nugget of science and then trying to extrapolate clinical information and making large sweeping claims about it. In a week or so, we'll talk about epigenetics and we'll talk about methylation. There really may be something to this MTHFR gene thing, but there may not too. I think it's really too early to tell. So when we look at studies, lots of times the Journal of Family Practice has something called POEMs, and this is problem-oriented evidence that matters. And they're truly looking at outcomes. Did the patient die? Did they end up with a serious disability? The problem is that we look often at a lot of proxies, and there's a pharmacologist out of British Columbia, a guy by the name of James McCormick, that has a bunch of very entertaining videos that reminds us the pitfalls with that. For example, we can show that increasing dietary intake of salt increases blood pressure. What we have not been able to show is that that actually results in higher mortality rates. Conversely, restricting salt will lower blood pressure. We have not been able to find any evidence that suggests that that saves lives. And in fact, there's a couple of studies that would seem to suggest that mortality rates are slightly higher, not necessarily even significantly higher, but slightly higher in the people that you restrict salt. So we have to be really careful with proxies. Cholesterol is another one of these, whereby we can show that lowering cholesterol does seem to have benefits. The problem is that we're not really sure, because there's a lot of people with low cholesterol that end up with heart attacks. There's a lot of people with high cholesterol that don't get heart attacks. So these proxies help us with probability, but the probability is not destiny. So we're going to try to learn some of the current knowledge in physiology. We're going to talk about how the thinking clinician can use this information to care for patients. Here's 3 scenarios that I've put on Blackboard. They are, Canvas. I'm going to be saying that all semester. I apologize. 20 plus years of Blackboard. It's hard to break the habit. So this is an 8-year-old. You draw his blood count because he's been feeling tired. Hemoglobin's 13.1 and his MCV is 73. So you've got to think through what are the possible causes of small cells like this. And there's also some specific genetic causes that you're going to want to think about. And John Smith is seen by a psych provider, does not seem to be getting better with the fluoxetine, brand name Prozac. The psych NP does this next test that's on the next slide. And you can see that they're testing for a number of different medications and testing some specific genes. For fluoxetine, that's an SSRI. They're testing the CYP2D6 gene, and they're seeing that this cytochrome P450 gene, that he is an intermediate metabolizer. What does that mean? Does that have any importance to his medication? These cytochrome P450 medications are really, enzymes are really the basis to all drug interactions, or at least the majority of drug interactions. So it is important to understand them. And Minnie LaRue is coming in for prenatal counseling. She says her mother thinks that her father had von Willebrand's disease. They divorced years ago. She's had no contact with him. What do you do? What is von Willebrand's? What kind of a genetic disorder is it, if it is in fact a genetic disorder? Is there a test for it? These are the kinds of things that you're going to have to think through. So go on Canvas. They're on the discussion board there. We'll have a rousing discussion, and then we'll probably try to touch base about these cases in a future talk.